So when I first gave my first presentation on Monday, I talked a little bit about the emergency nurse practitioner certification. Was asked to mention that again since it was right after lunch. But for those of you that are NPs, you can listen up. The rest of you get a little 5-second break. But now for those of us that are NPs, we do have a certification now for emergency nurse practitioner through the American Nursing Credentialing Center. If you're interested in that, please check out the website. It is not a entry-level certification. It's going to be a subspecialty for those of us familiar with the consortium model. They talk about populations, and they don't consider emergency to be a population. We do now have a subspecialty certification for that. Feel free to talk to me. I'll be glad to give you some information. It's all available on the ANCC website, but does give us a chance now to have some way of certifying that we are practitioners' expertise there in emergency medicine management on top of whatever their credential, whether it's family or acute care or even pediatric in those areas. But please check that out. So then we're trying to spread the word. It's not ideal yet, but at least it's a starting point to get us up to that level to have that certification. So let's talk a little bit about elbows and forearms. And it'd be great to do just to go, there it is, that's all we got to talk about it. But unfortunately, we'll spend a little bit more time talking about the different parts of that. As we talked about yesterday in one of the question answers, about the different terminology and do we need to know all the specific terms? It's great if we could use those, especially when we're talking with ortho, but ideally if we at least know the landmarks, know the anatomy of the different bones. We're talking about whether it's the radius, the ulna, actually the olecranon, along those aspects, to give us a better idea where we're looking for those different types of injuries. The big thing we need to think about with the forearm, especially the elbow, and we'll look at it in just another slide in a second, is that those two bones are connected. They do form that ring. And so when we consider for one type of injury, we always have to be sure that we look at the other bone for any other type of injury as well. Same that we talked about with the tib-fib, those two bones move together. We have a lot of different muscle compartments there. We don't often see a lot of compartment syndrome in the forearm, but definitely has the option for that because we do have a good bit of compartments there with the different fascial layers there with our either extension or movements that we may see with those different patients. But there are a good bit of there with the extensions and with the flexors. We do have that interosseous ring, as I mentioned there, between the radius and the ulna, and for those moving that ring-like pattern. So anytime that we do see a patient that has that distal radial injury, which is a very common thing, we've got to make sure we always examine the ulna to make sure. We talk about people that have the Colles fracture, they have that Fuchs injury, and we see that very impacted distal radius fracture, but do we see that ulnar styloid fracture that may come along with it? So just be sure to always keep that in mind, that if I see one, do I have a good chance of having something with the other one? Absolutely. To make sure that we examine from top to bottom, do I see any other type of injury that may see there, that usually when there's one bone, there's probably two bones involved with that. As we talk about from general orthopedic stuff, always remember that it's always the joint above and the joint below that I want to make sure I assess. Do they have any other type of injury? And of course, obviously, assessment and documentation, their circulation, their movement, and their sensation is utmost importance. Especially if we're going to do some type of manipulation, whether we're going to do a reduction or even just a mobilization, have I compromised that? I want to know what their baseline is, especially if they came in by EMS, they've already been immobilized, or they've come with another injury. What is our baseline, and if we do any type of manipulation, have we impaired that? Because I definitely want to know where they're at when they go home or where they're at before and after I do something to make sure that I haven't compromised their circulation. Or if they had a deficit there, that it was already there prior to any manipulation that I did with those patients. For the most part, a lot of these, we can either immobilize those and have them follow up, and that may be as simple as just doing a sling. Not everyone's going to need, some type of fiberglass splinting, but for the most part, especially in some areas, we never can really be wrong on the side of actually splinting somebody and giving them follow-up directions to go with that versus not doing anything. I'm not aware of any cases where people got in trouble for immobilizing a thing for a couple of days versus not immobilizing them, missing an occult fracture, and then having some complications along with that. So we talk about different patients and who needs an x-ray, who needs just a good physical exam, and one of those areas is the elbow. And for the most part, if the patient's able to do a good full extension out, and about 95% of those people are going to have normal film. So we necessarily don't really need to get a film on those patients. If they have point tenderness, they can go, it hurts right here, and they can point specifically right there on the olecranon. That patient may be more likely to have some type of injury. But for the most part, especially adults and even kids, if they can get a full extension, they probably do not have any other type of bony injury. They may have some soft tissue injury, but if they can get a full good extension there, those patients probably will not necessarily need an x-ray, and we can treat them symptomatically and definitely always have them follow back up. So fat pad analysis, we talk about this a lot with pediatrics, but also can play some with kids as well, that we talk about to look for those occult fractures that sometimes are very hard to see. Now with a lot of digital films, it gets a lot better. We can actually really zoom in, change the review, and get a much better detail of those, but fat pads can really help us identify those. Sometimes we will see anterior fat pads, and those can be common. Those can be normal, as long as they're small. But if we see a large anterior fat pad, that's always abnormal, and posterior fat pads are always abnormal. We should never see those visualized. And if I'm seeing some swelling there in that posterior, there's a fracture there somewhere. We need to look for it. If I can't identify it, it's still there somewhere. We can treat that patient for that. But always get a good idea to look for those. And if I see that small anterior, that might be normal for the patient. But definitely if I see a large anterior, and anytime that I see a posterior fat pad, there's some type of fracture there. If all else fails, immobilize and have them follow back up, and that's definitely going to preserve and decrease the risk of complications. So we can see here in these two films, you do see that one film, very small anterior fat pad, that's most likely normal. We don't see anything else there. But in that other film, I definitely see a large anterior and definitely see that obvious posterior fat pad, which definitely indicate there is that fracture. You can see there's a very subtle fracture there of the radial head that shows up there. So just keep those in mind. If I can't see a fracture, they're really tender, but I see those fat pads, immobilize. Have them follow back up with ortho or get that ortho referral, or for us NPs and PAs, definitely have our second set of eyes look at it. Where I practice, we get overread almost 100% of the time at radiology. It's great, but definitely not a bad idea to have two sets of eyes versus one. Definitely to look and see if we see anything else before we discharge that patient and tell them. And I'm also a big proponent on, today we've looked at it, I've looked at it, the radiologist looked at it, we don't see anything. Most likely there's not a fracture there, but there are some fractures that can't be seen initially, and they may show up in a couple of weeks. And it's never wrong not to inform the patients that we don't see anything today. That doesn't 100% rule out that there's not something there. We're going to treat you the same no matter what. And then that's when it's important for them to follow up, and that hopefully may help improve their chance of them actually following up, knowing that there could be still something there, we just can't see it yet. The radial head fracture being probably the most common that we'll see there in that space with the adult patients. But those fat pads will definitely help us look for those areas. Do I see that posterior? Do I see that very large anterior? And that will work. There's differences out there of how long they should be immobilized. For the most part, for us in the ED or urgent care areas, we're going to immobilize them for a couple of days, and that's why it's important for them to follow back up. Definitely wanted to make sure that we've stressed that importance with them in their discharge education. We've documented that, and that's about as far as we can go. We can't call every one of them and make sure, hey, did you follow up? But definitely stress the importance that this is a temporary immobilization to help prevent further injury, to give them some comfort, but definitely that follow-up is always going to be an important aspect. Here on these films as well, as you can see, there's that very subtle fracture there of the radial head, but you definitely have those fat pads that kind of stick out there and go, yep, there it is, especially that posterior film that we see there definitely has that little fat pad. Helps us a lot in some of those situations where I really can't see that fracture. It's not sticking out and yelling at me and going, hello. So our supracondylar fractures, we see those a good bit in our pediatric patients. One thing that will help us do with these a lot is we look at the humeral line and we line that up, looking at that film between the humerus and there through the radial and the ulna to see if we have a good 90-degree angle with that place and where it actually falls there with the capitellum. If we see a nice, good line that goes through about the middle section of the capitellum, we probably have a normal bone film. But if I see displacement of that line, that's going to give us an idea that we probably have some type of injury there to that bony structure that's definitely going to allow us to see that. So as you can see here, if we draw our nice line down through the humerus and out through the radial head, that gives us that nice intersection. And we put that on top of this film here, and you can see that it goes right there through about the middle section, the middle third of the capitellum, and gives us a pretty good, nice placement. But if I place it on this film, and I look there, it's not through the middle section as well. And of course, there's a pretty obvious fracture there that hopefully most of us will be able to pick up on. But in those subtle fractures, this definitely gives us a chance to look to see, does it go through that middle section? If it does, great. But if it doesn't, then there's something else there that's displaced that line and increases my chance. I need to look a little bit further. And if all else fails, splint, immobilize, and have them follow back up. And this patient's obviously got a very big posterior fat pad sign that's definitely going to key us in. There's some type of bony injury there. So we talk about the elbows and talk about the difference between adult and pediatrics. The biggest thing is for both of those, if they can get that lock and full extension, that's a pretty good indication they probably don't have any significant bony injury. If they can't do that or they have that point tenderness, then that definitely increases the chances they may have something. I need to look a little further. That humeral line analysis is going to help us, especially with both pediatrics, but even also for adults. And the fat pads are still a very good thing to look for. Small anteriors are okay. Anytime they have a large anterior, definitely have that large posterior. Any posterior fat pad is definitely going to be an abnormal finding and definitely needs to key me and I look a little further because there's probably something there that we can see with those patients. If in doubt, it's always important. A good physical exam is going to trump anything else. Radiograph if we need to, splint it, immobilize it, and have them follow back up and document that is going to be one of the best things we can do to make sure that we prevented further injury and hopefully give them some stabilization if there's something there we suspect. So epicondylar fractures that we'll see a lot in our pediatric patients. More common there in that young explorer age group, 9 to 14. They're in their school age years. They're liking to get out and explore and do different things. Our avulsion fractures are very common, as you can see here in this film. Necessarily won't always see the fat pad signs with these. So that does make it a little challenging. It takes out that nice little key that we have that may help us identify those by looking, going, oh, fat pads look okay, but you may see, especially with these avulsion fractures you can see in this film here, that may help us identify that. We can use our Salter-Harris classification system, and these are sometimes one of the ones that actually gives us really good help to get that comparison view. If I don't have the ability to look at it really good, to go ahead and get the other arm and look to see. Because some people will have some, what we consider looks abnormal, but it's a normal variance for that patient, or sometimes in those different patient populations to see, do they look the same, do they not look the same? If in doubt, we can always immobilize, have them follow back up, and definitely have that seen but ortho in a couple of days, because usually they're going to require some surgical intervention for these injuries. Our growth plates can sometimes be misleading for some people. They look at that and go, oh my gosh, there's a fracture there. And of course, we can always think that especially as they move through their pediatric years, those are going to start to close off. But our growth plates, for the most part, look very smooth. They're very clean lines. That's one thing we can usually look to go, fracture versus growth plate is how does it look? If it's nice and clean and smooth, most likely it's a growth plate. If it's jagged, very irregular looking, then we're thinking more about a bony injury that may help us with those. But we can think about the cryotonomotic to help us think about how it's going to close in those. And the comparison views is always a good choice to look to see, because ideally, if they're on one side, they're closing the same time on the other side to get a chance. Yeah, that's normal or that's not. And I'm always a favor to calling the radiologist and saying, hey, can you look at this? And now with digital films, it's pretty easy to call ortho at home, and they can pull it up at home on their laptop or something on their phone and go, okay, yeah, we'll see them in the office tomorrow. Or no, we'll do this, we'll do this. So technology has really helped us with that, but definitely always falls back on the clinical exam. Do they have point tenderness? Do they have deficits? If there's always a concern, then treat it as such, and they can follow back up. Elbow dislocations. What we're going to see is the posterior ones, especially from those Fuchs injuries, those fallen outstretched hand, which we see a lot as we get into the winter months for some of us with ice and stuff. But people fall, what we're all going to do is put that hand out to protect your face and may easily get those distal injuries here, but also those posterior dislocations of the elbow. These can usually be produced pretty well. Procedural sedation helps us a lot with those patients. The thing to think about is if we do reduce these, what's the best way to mobilize them? And there's some discussion, oh, they need a mobilizer, some that they need a sling. And for the most part, either are very effective. The biggest thing is we do want to make sure we immobilize them. Once we reduce that, make sure we have good evidence they've got good circulation, good movement sensation that has not changed since we did the reduction. And the patients that continue to have these problems may have to have some other type of intervention, but definitely we want to make sure that once we reduce it, any type of dislocation, we've talked about with several of these, we do have a way to immobilize it, because it's nothing like putting a joint back into place and before you get a chance to immobilize it, they wake back up and then it's out again. We definitely want to prevent further injury, and that's one of the important things with that. And for a lot of things, the sling will work very well for these patients. The Olecranon bursitis, they come in, they've been working, doing something that's irritated there right over the Olecranon. We always have to worry about, is this some type of foreign body? Did they actually get something that actually penetrated that space? Were they crawling around, they're working, and they actually got a foreign body in there? Is it just from abrasion or some type of inoculation type area? Or is this just irritation from the bursa itself? So we have to keep those different things in mind. Sometimes an x-ray may help us if we're worried about a retained foreign body, especially they said that we did come down and felt like there was something in there. We want to look for those. Gout could definitely be a cause there that we'll see in some of these patients, as well as rheumatoid, but not always common. If we do get an x-ray, you may see that calcium deposit that we'll look at in just a second. So if that area looks really red, really swollen, really angry looking, then definitely I am worried about it could be an infectious process. And one thing that can really help us differentiate that is actually doing an aspiration, prepping the area and aspirating to see if we get what we get back out of it. And if I'm getting that very turbid, very cloudy looking fluid back, then most likely that is an infectious source. So we can send it off for cell counts and even do a gram stain for that. But if the area itself is looking very swollen, it's tender, but it's not very red, it's not very angry, then most likely that's not an infectious process. That's just a true inflammation of that area, and that may do very well with doing some localized injection of either some anesthetic, but also some steroids. So as you can see here in these films, this first one, very inflamed. It's red, it's angry looking. That one's the one I'm really worried about, could be an infectious process. I definitely want a good history. I want to know what happened when it started. Is there always the concern for some type of retained foreign body that I might have to deal with? But on the non-inflamed one you see there, it's swollen. It's probably very tender, but it's not red, it's not inflamed. It doesn't actually show aspect of that inflammatory process. And then x-ray right there in the middle, you can see where they've got that little calcium deposit that may sometimes be visible on the x-ray as the inflammatory process continues on. They get some calcium deposits there right off the Olecranon. And then the nursemaid's elbow, something we see commonly that presents both the ED and those of us in urgent care as well, that somebody grabbed the kid and pulled up on the arm and may have subluxed the radial head, allowing it to slip out a little bit and get that ligament caught there in the place. One of the biggest things that was used as they come in is they're neglecting that arm, they don't want to use it. It was immediate onset of discomfort for the patient, and they stopped using that arm pretty quickly once that injury happens. Very common in the 2 to 3 age group, and a lot of times these will reoccur. And so one thing we can do, if we feel comfortable with the parents' ability to comprehend it, is educate them how to reduce this themselves. And some kids may have several episodes throughout childhood, and if the parents can reduce it themselves, it'll save them a trip to come see us. But just as we get that little sublux there, the radial head, as it slips out of its place a little bit right there, and that ligament gets caught there in the groove. So the way we used to manage these was just doing some nice supination and flexion, putting a little pressure over there as we started to turn the hand. But actually a newer technique with the hyperpronation is actually been a little bit more successful, and I've actually changed my practice. And looking at some of the studies, actually doing the hyperpronation actually is supposed to be not as painful and not as uncomfortable for the patient. And you can still do the application of pressure to the radial area. And as you hyperpronate, it actually may slip in a lot easier and not be as discomforting to the patient and may not increase their anxiety along with that. But whatever tends to work best for you, you may have to do it once or twice, but for the most part, x-rays are not necessary. It's the classic presentation, and usually within several minutes, they have a return of function, and they'll start using that hand pretty quickly once you've reduced that, because once it's back in place, the discomfort's gone, and they're gonna start using their hand pretty quickly. Different type of distal forearm fractures that we'll see, and always talking about earlier, if I see one injury to one bone, always keep in mind there's always the option of having that secondary bone injury. So we see here with the Colles fracture, that distal fracture, but to be a true Colles, it's also got to have an ulnar styloid involvement with that. So be sure that we always look at both bones. If we have really good terminology to use those, or we're talking to whomever that, oh, it's a Barton's or it's a Smith's, those are great, but definitely make sure that we always look to see if one bone's involved, is the other one involved, and obviously good circulation, movement, sensation is always of utmost importance. For the most part, most of these we're going to splint and refer those out. Some of those that have a lot of angulation, if we do those, we may do a little procedural sedation, the ED, and try to do a closed reduction to at least line those back up a little bit better, or ortho may even come do that for us there in the ED. But we definitely want to see what type of involvement they have there. Definitely want to make sure that we have good documentation, again, of their CMS, that there's no change in their circulation, their movement, or their sensation. And definitely if I do any type of manipulation, it's always very important that I've reassessed that and document that when they went out, they had good cap refill, they had good movement of the distal extremity, and they had good sensation that was intact, and make sure we always document that. And these may need to follow up with ortho for operative intervention. We may always want to get just that side consult with our physician colleagues, or even ortho on the phone to say, here it is. They'll look at it and go, oh, great, splint them, we'll see it in the office tomorrow. And that's what I've seen in a lot of my practice. They don't like to come to ED anymore. They used to. Now they just want to see everybody in the office, and they'll do them tomorrow or the next day. But talk to them, document that, and with those digital films, we can get a lot of good, quick consultations very quickly. The Salter-Harris classification we mentioned a little bit earlier. Try to remember where these fall out with the growth plates. The slip above, lower, through, and ram is a good technique to kind of remember which one falls with which. But definitely something we need to think about when we look at it in documentation for our pediatric injuries, and definitely makes us concerned of where they're at there in that growth area, and if it's going to be detrimental to growth and development later for that child. but just going to give some visualizations here about the above or the ram, the lower technique, and how we see it involved there with the epiphysis. But the importance of knowing that they've definitely got to have follow-up. They definitely want to make sure that we have proper realignment and proper repair of these bony structures, that we do have normal return of growth and function of that bone area, and we don't have some type of loss of function later in their adulthood. And our last thing to talk about is the overuse syndromes. We talk about whether it's lateral versus medial epicondylitis, whether they have the lateral, the tennis elbow, or they have the medial, the golfer's elbow. And they're going to have pain with movement. And these are not always seen with the tennis or the golfers, but what kind of work do they do? You know, it's so important to get a good social history. What kind of activities have they been doing? Have they been doing anything that's going to increase that risk of having that inflammation of that area, and may definitely benefit from some rest? We may immobilize them, we may just put them on NSAIDs, but definitely want to let them know that this is going to get better over time. Not going to happen overnight, but definitely rest is definitely going to help that. And some patients, they're going to continue doing what they're doing. They're going to continue to have those problems throughout, whether it's related to their occupation or related to some type of activity they're doing just for fun. And the last thing in decursive ends, tenosynovitis, if they're having that pain there in their wrist, if we can do the Finkelstein test and actually have them flex down, that gives some pain right there. That definitely is pretty indicative. And they're going to have some painful crepitus over this area if we actually palpate. So if we have them do, whether they're doing up with good relief, no pain, but when they go down, or if I flex them down, they're going to have some tenderness and some pain through this area, or definitely when they have them do that, I'm going to feel some crepitus through that area. That's going to indicate they probably do have that. They're going to benefit from some NSAIDs, benefit from splint and mobilization, and always follow up. We're talking about any of these different types of injuries. But the big thing we talk about with the elbow and also with the forearm is good assessment, good documentation of what their circulation, their movement, their sensation is prior to and after any manipulation. And if all else fails, immobilize. Immobilize, educate them, and have them follow back up. But if they don't need the immobilization, great. But I'd much rather immobilize something I'm not sure about and then have them take the splint off in a couple days when they see ortho and they don't need it, versus sending somebody home with an occult fracture that wasn't immobilized, and now we're having complications from that. Thank you all very much.